folks. You're listening to the Jobs Podcast. I am your host, Tim Hendricks. Your time is valuable. I'm not going to waste it. Let's get right to the interview. Hey, folks. You're listening to the Jobs Podcast. I am your host, Tim Hendricks, and we're going to go ahead and get started with Dr. Caleb Davis. He is an orthopedic surgeon, specializes in shoulders, but he could probably fix any bone if you asked him. So he's also the host. Him and his wife they host the Wellness Blueprint podcast. You can find that on Spotify, Apple Podcast, YouTube, and Amazon. And is there anywhere else that your show is found, Dr. Caleb?
I'm pretty sure it's hosted just about everywhere. You know, I use Buzzsprout to host my services. They get it pretty much everywhere you can listen to podcasts.
There you go. All right. Well, let's go ahead and get started with the origin story of Dr. Caleb. Where were you born? And just kind of walk us through your youth and your education, and we'll go from there.
I'd love to, and thanks for having me on the show, Tim. I really appreciate it.
You bet.
So I was born in Orlando, Florida. Kind of rural part of Florida, which is hard to believe now since it's such a developed place. But born and raised in Florida, moved out to Tennessee for undergraduate school. Believe it or not, I just thought I was going to be a professional musician before I spent most of my life being a musician. I started playing the cello when I was 9 years old. And got really, really into it, really enjoyed it. Actually, that's how I met my wife. We met when we were 13 years old. We were in the middle school orchestra together. She plays the cello also. And I got a full scholarship to the University of Memphis to go be a professional cello player. And so I took full advantage of that. And, you know, you wouldn't believe this, but there's actually a lot of injuries associated with being a musician.
Really?
Not like big injuries like shoulder dislocations or fractures, but more like a chronic tendonitis, carpal tunnel syndrome, that sort of thing, you know, nerd injuries.
Sure.
But when you're a musician on the college level, you're expected to play about 6 hours of music a day. And I just got burned out with it. I really love music. Music's still a huge part of my life, and I still play. But I said to myself, I want to do something a little bit more tangible with my life. I want to do something that is a little bit more, I can see the effects of how my work helps people. And music just wasn't doing that for me. And that's when I got really interested in anatomy and physiology. I should actually go back just for a second on that story, because when I got to college, I gained the freshman 20. You know, they talk about the freshman 15, you gain 15 pounds when you get to college. Well, I got the freshman 20. And I looked at myself as I don't like what I see. I want to get healthy. I want to be in better shape. And that I took a deep dive into nutrition and health, and that's really kind of how it all started, really, if I'm being honest, when I started learning about diets and nutrition. But after I took a deep soul search into what I really wanted to do with my life, that's when I said, well, maybe a physical therapist or something that to do with the body would be interesting. And then I said, you know what? I want to go straight to the top. What's the hardest thing I can do? And that's become a surgeon. And that's kind of how it all started.
So what was the first, you're choosing, this is my career. What school am I going to go to? Did you think that you wanted to focus on orthopedic surgery, or was there another aspect of surgery that you were looking into? Just kind of walk me through the fine tuning of ending up as an orthopedic surgeon.
Yes, I was not completely set on orthopedics at the time. I just knew that I wanted to do something with my hands.
Okay.
I had good dexterity from being a musician. I think working with my hands would be really nice. So surgery sort of as a general category. And I didn't know a whole lot about being a surgeon. So the first thing you really need to do is, if you're interested in medicine, is go shadow doctors, work with other doctors and see what it is they do. And there's a place in Memphis, Tennessee, where I was doing my undergraduate work called the Campbell Clinic, which is this huge orthopedic practice. It's actually the oldest orthopedic residency program in the United States. And I went and worked with the chief of sports medicine there, and I remember seeing him do an ACL reconstruction, which, for people who don't know, it's a ligament in the middle of your knee, and you take a cadaver graft or a graft of tendon from your body, and you recreate this ligament in your knee so it's stable. And it just blew my mind. My jaw was on the floor watching the surgery and seeing what they do. And I was pretty set from that point on, just as a pre-medical student, seeing orthopedic surgery, and I was in love.
So you've decided you're going to medical school. What's the class shift or the study shift that occurred? I mean, you were already in college. How far were you into it with the cello before you decided you were going to go to medicine?
I was just starting my junior year of college when I decided.
Oh,
So
wow.
it
Okay.
wasn't on my radar before. I didn't have any pre-medical prerequisites.
Okay.
So there was not much overlap, as you can imagine.
Yeah.
As a musician, you had to take a lot of music history, music theory. You had to do music education, all these other sorts of classes. You were required to do some basic humanities, English. You had to take one science and one basic algebra class as a
Hmm.
musician. So I had no overlap at all. So I had to go meet with a counselor, an academic counselor, say I want to do pre med, and they guide you through the process and they tell you all the classes you have to do. So, just a quick rundown: it's chemistry 1 and 2, physics 1 and 2, biology 1 and 2, organic chemistry, calculus. So, I was like, okay, I'm already a junior. I need to get on the game, and just so I don't graduate in 7 years. So I ended up
You're
taking
playing
summer
catch up big
classes.
time.
Yeah,
Yeah.
that's right. Lots of catch up. So I
Yeah.
took summer classes. I took like full credits every summer, and only graduated one semester late with all my pre med requirements.
Oh, wow. Okay. So then after you finish with all your pre-med stuff, then you apply to medical school. And that's correct,
That's
right?
correct. But you also
Okay.
have to take a test called the MCAT, which is the it's I don't remember exactly what MCAT stands for, but it's medical aptitude test. I don't remember what the C stands
Okay.
for. It's been a long time since I took it, but it's a
Right.
standardized test that everyone has to take to get into medical school. Most professionals have it. The lawyers have it, like the LSAT to get into law school. And
Okay.
the your performance on the MCAT, you get a score, and you submit it to medical schools along with your GPA and your college resume, and they basically rank you on that and decide if they want to give you an interview into medical school. So that's another one of the big requirements.
When you get accepted to medical school and you show up, am I correct in assuming that everybody starts and you're going to everybody's going to basically learn how to be a general doctor, and then after that is when you dive into your desired specialty?
Yes, and I'm glad you brought that up because I found that a lot of people really have no idea the progression of what it takes to become a specialist in medicine.
Yeah.
You're absolutely correct. Pretty much everyone who becomes an MD, so a doctor of allopathic medicine.
Hmm.
There's different types of school, but that's the standard one everyone thinks of. They all go
Okay.
through the same 3 years of medical school, and it starts off in the classroom. You're doing a lot of lectures, a lot of interactive studies. In addition to that, you're also doing cadaver dissection work on a deceased person, learning the anatomy and all of that from head to toe. After 2 years, you go into the hospital and start working in a clinical setting in doctors' offices and in hospitals and actually getting hands-on training. The fourth year is a little bit more flexible because you're starting to get an idea of what you want to do and you're applying for residencies. So that's post medical school training in your area of specialty. So
Okay.
you're able to craft your fourth year a little bit more and do a little bit more of the things you want to do in elective time. And so I spent a lot of time in orthopedics for that, obviously.
I didn't realize that residency, I thought that was part of medical school, but if I'm understanding you correctly, you finish medical school and then you get a job. You're paid as a resident, correct?
That's correct. The vast majority of doctors after medical school go to a residency. In fact, it's pretty hard to get a job if you don't do a residency. That
Okay.
would be mostly, and I'm speaking a little bit out of ignorance here, but most of the jobs I've heard of is being a insurance adjuster, for a company as a medical
Mhm.
doctor that did not perform a residency.
Okay. All right. So you're applying for your residency. Is that one of those things where you're kind of starting all over again? You're new, you're looking nationwide, and you just submit applications, or are there certain areas where they kind of recruit you, or how does that all play out to get a residency?
It's different for every specialty. So there's what we call the competitive specialties, and then there's the ones that are less competitive. And the culture of getting a position in one of those residencies is actually very different. So if you think about internal medicine, meaning someone who just takes care of the adult with someone who has diabetes, or if someone's in
Hmm.
the hospital with pneumonia, that would be an internal medicine doctor. Pediatricians, obviously taking care of children, or what they call family practice or a primary care doctor. Those are considered less competitive. And so they
Okay.
do sort of try to recruit you, say, oh, we'd love for you to come to our program and work with us. And here's why it would be great. And then things like neurosurgery, plastic surgery, orthopedics, things that are considered incredibly competitive. It's much the opposite. You have to sell yourself. Why should we choose you to come to our
Mm.
program? In fact, over 50% of the people who apply to orthopedic surgery don't get into the specialty. They don't get to do it.
What's the residency length like? I'm assuming it depends on your specialty.
For example, any surgical specialty, whether you're a ear, nose, and throat surgeon or what they call an otolaryngologist, orthopedics,
Mhm.
neurosurgery, there are going to be 5 years or longer.
Oh,
Where
wow.
a general, like a medicine, pediatrics, family medicine, those tend to be 3 years. So it's quite a bit longer. Neurosurgery is actually a 7 year residency. So it's the longest one.
Good grief. You always hear about doctors, the residency is just such a grind. You kind of fall off the face of the earth for a while and you're just living at the hospital in long hours. And is it pretty much that way in all of them?
It is. They're all grueling. Yeah,
Yeah.
any doctor who went to a residency it's a very intensive process. The reason they call them residents is because they were residents of the hospital. They lived there.
Oh, okay.
That's shifted a little bit now, but not that much.
Yeah.
If you talk to any resident, they're going to have a work week that's lasted 80 hours for them before.
Oof.
The most I ever worked for an entire in a week, I think, was around 110, 115 hours though.
Wow. That's brutal.
It
The
it is, and it's just part of you. You don't really remember those 5 years. It's kind of all a blur.
so when you start your residency, what's the transition like from when you're observing, you're in the operating room to when you're actually doing the cutting and the work? Do they ease you in and help with different stages of it while the more experienced surgeon is there, or how do they kind of basically guide you to be where you can do it on your own?
Every residency is a little bit different, and I'm going to speak from my experience.
Sure.
And it's called graduated responsibility. So when
Okay.
you're a first year resident, what we would call an intern, you are basically just observing and assisting.
Okay.
And then let's just say someone's broken their femur and you are your first year. You'll hold retractors, you're holding muscle and skin out of the way while the senior doctor is working and they're sort of talking you through their process and teaching you what they're doing. And they'll let you say, "All right, I'm going to let you close the skin and I'm going to watch while you do it." That sort of thing.
Okay.
When you're a second year resident, they'll say, "All right, I want you to start the surgery. I'm going to watch you do it, and I'm going to take over if you don't know what you're doing," sort of thing, for lack of
Right.
a better word. And then in your third year, there's like, I'm actually gonna leave the room and come back and check on you. You've at this point you've been working 100 hours a week and you've seen a lot of things and you've been lectured. I mean, your whole life is surgery. It's all consuming.
Yeah.
And by the time you're a fifth year resident, you're actually the one teaching the younger residents, and the attending surgeon may not even come in and into the room at times, although the they'll come check your work, but it's graduated responsibility. And by the time you're a fifth year resident, you have to imagine you've done 4 years of medical school and 5 years of surgical training, and where your entire life is surgery. You pretty much know what you're doing by that point.
My goodness. I didn't realize it was quite that long. It's just the residency, especially. But when you are in there working on a patient, that first time that you cut into somebody, I mean, do you have those little snapshots in your mind where I specifically remember the first time I cut into a knee or a shoulder or whatever?
I absolutely do. Yeah, I'll
Yeah.
never forget the feeling when the first time you're holding the scalpel and you cut into a live person's skin. You're
Yeah.
just praying and say, "I hope I don't mess this up."
Double checking to make sure you got the right leg and or the right shoulder or whatever.
There's multiple redundant processes to make sure you don't have what we call a wrong site surgery. I've
Right.
never been a part of a wrong site surgery or witnessed one, but you don't want that to happen.
When you hear about these surgeries, and my son had a kidney transplant when he was 4, and so I remember sitting in the waiting room for, I don't know, 6, 7 hours, and it's just such a long process, and I've wondered, when a doctor has a surgery that is so long, do you do it in shifts with other doctors on major surgeries like that or long procedures? Or is it literally just one doctor that's doing the whole thing? Because I would imagine that's got to be tough on your mind and your body to be hunched over a patient for 5, 6, 7 hours.
It certainly is. I've actually worn like a Whoop strap or other biometric device to count my calories during surgery, and it measures it as intense exercise.
Oh my
Uh,
goodness.
it's definitely it's definitely a long process. It's definitely grueling. However, it varies. It depends on the surgery. There are what we would call multidisciplinary surgeries where you have a team of surgeons working on a patient. The longest surgery I've ever been in was 8 or 9 hours. And I stayed in there the whole time this was as a resident, not as an attending surgeon not the
Mhm.
senior surgeon. And we never left the room. However, I have heard of longer surgeries that take 10 to 20 hours where they do have shifts where someone will come and assist you so that you can go to the bathroom, eat something, drink something. That certainly happens. Not
Yeah.
quite as common in my field.
Hmm. So you've gotten into orthopedic surgery. How did you dial in on shoulders? Or is that all that you do now? Is that your main focus? Like you're the shoulder guy, or do you mostly focus on shoulders but do other joints as well?
Great question. I get that question a lot.
Yeah.
I am technically, we all do the same 5 years of training as orthopedic surgeons. So I can do hip and knee replacements. I can fix a broken femur, fix a broken tibia, fix a broken ankle. I do all those things, and I still do. My passion is for shoulder surgery. It's what I do. Probably 80% of the work I do is shoulder, but I can't focus just on that. There's too many patients who need other things.
Mm,
I live in a fairly small city. So if you go to a larger city, you will find surgeons who do nothing but shoulder, nothing but hips.
mm,
But you have to live in a pretty large city where there's specialists who do nothing but the one thing. So I still do a lot of general work. But I did an extra year of training that I did nothing but shoulder and elbow surgery. So on top of the 5 years of residency, I also did 1 year of that. So I can call myself a specialist who did extra training to be certified to do this.
What was it about the shoulder and the elbow that kind of drew you to it?
Couple things. They've been doing hip and knee replacements since the 1960s. Hip and knee replacements are old. They've been doing them a long time. They've become very, very good. Shoulder surgeries are just starting to catch up in terms of complexity and modern innovation. And
Mm,
I look at shoulder surgery as the new frontier in orthopedic surgery. We're coming up with all these new tips and types of designs of shoulder replacements. And we were talking a little bit before the show started, all these different ways to fix a rotator cuff in the shoulder.
yeah.
I saw this as a way of getting into the front line of something new that's going to be the big boom in medicine, and I wanted to be part of that. So that's one reason. The other is I also was a competitive power lifter, and I just loved the bench press. And it's such a stereotypical thing for an orthopedic
Yeah.
surgeon, but we all like to lift weights and exercise, but I really did. And I looked at the shoulder as the most complex joint in the body with just the most degrees of freedom and motion. And I said, that's, again, I want to have the most challenging thing I can do. And to me, everyone thinks about the hand as the most complex part of the body, and it is. It's incredibly complicated. But to me, the shoulder is the thing that puts the hand where you need it to go.
Ah,
Once you lose your shoulder, you suddenly realize that hand and elbow is not going to do the job of giving you dexterity. That the shoulder is what puts it where it needs to be, and that's my long-winded way of saying I just love shoulders.
no, that's fine. What is you talked about the knees and the hips and how they've gotten really good at them. When you look at the past and then what's coming up on the near future as far as rotator cuff or labrum or joint replacement in the shoulder, what are the things that you are seeing that are headed our way that kind of get you excited about the next surgery?
Yeah, there are a few things and that come to mind that I'm trying to be on the front line of innovating. And one of them, when traditionally when you had to do a shoulder replacement, there's a muscle that runs across the front of your shoulder called the subscapularis, and we always had to cut it off and to do our work. One of the big innovations is we're figuring out new techniques on how to leave that muscle on and work around it to do a shoulder replacement, which
Okay.
traditionally we would leave someone in a sling anywhere from 2 to 6 weeks after surgery. Now we're getting that sling off in 1 week and letting them start moving again immediately, which is
Mm,
more what you'd think about after a knee or hip replacement. And so we're sort of catching up in that way. Another big problem with shoulders is that they wear out over time. We put in metal and plastic and they start wearing out.
mm.
And so they're coming up with new, different materials that are more durable that we're thinking are going to last a whole lot longer without causing damage and having to go do more surgery in the future. So that's another really exciting thing.
Is that a titanium or ceramic, or what are they typically using for the new joints?
So traditionally, we used an alloy called cobalt
Okay.
chromium, and this newest one that I've starting to implement is actually a pyrocarbon, which is so it's a sort of carbon derivative that matches the roughness and what they call the um, elastic modulus of bone. So it's more similar to bone, so your body doesn't react as strongly to it. Don't even ask me the mechanical properties because it's the process is sort of like superheating carbon to overlay it on top of a metal sphere, and
Hmm.
it has to reach insane degrees of heat to be able to work. But it's all about matching and making it the most anatomic and like the human body as possible. So it's very exciting. It's still pretty new in the United States, so we're still publishing data and looking at long term results. But I think it's a very promising technology.
When it comes to orthopedics, like the joints and whatnot, do you find that most of the advancements happen overseas? I'm assuming in Europe or Germany, and then they work their way to the United States, or how does that typically play out?
Typically, the regulating bodies in Europe are not quite as strict as the FDA. So a lot of times, what will happen is, and we have innovation here in the United States too. We
Yeah,
we, we do.
sure.
We have great tech, but a lot of times they'll have some sort of tech in France or Germany, like you said, or United Kingdom, and they will get it on the into people before we do, and then the FDA will say, okay, they've had it over there for 10 years and it's not catastrophic, so we'll let you start using it over here now.
I
That's
see.
generally the way things go. And there's some really good tech from France in particular that we use in shoulders that are starting to become more popular over here.
Is the is it arthroscopic where you have the holes versus one large incision? Is that am I using the correct term?
Yeah, arthroscopic is refers
Arthroscopic.
to put arthroscopic refers to putting a camera inside of a joint, so you can do that for hips and knees and wrists and elbows and shoulders. Most of my rotator cuff work or any what we call soft tissue work is
Hmm.
done arthroscopically. Although for a shoulder replacement, there's you're putting large pieces of metal. You really can't do that arthroscopically, so you're doing that
Right.
through what we call an open surgery.
Okay. You had mentioned that you were into powerlifting. I was looking at your podcast website. There was something mentioned about jujitsu, and we talked before the podcast about you do some of that kind of stuff. Have you had injuries on your shoulders, or have you learned exactly how to move and what to avoid to prevent injury?
I definitely have had injuries. Thank God I've not had to have any surgery yet. As a
Mhm.
surgeon, I do not want surgery. But I
Comforting. That's comforting.
well, it's just I know what people go through, and
Yeah.
and for my patients, I also avoid surgery for them whenever I can. But a lot of
Right.
times I have to take care of them. But I know what they go through. I don't want to go through it.
Yeah.
Um, but I think for jujitsu, I've had some minor injuries that have healed without surgery. I think that I'm very body aware because of my expertise and knowledge, but I don't think you're always working with somebody else, so it's always going to be a little bit unpredictable. So
Oh,
you
yeah.
can't control all factors, especially when you're competing against somebody and their goal is to, in a controlled manner, is to hurt you.
Mhm.
So I had a partial tear of my lat tendon that goes up to my right humerus. That healed, and I'm currently recovering from an MCL tear in my right knee, also a partial tear. So both of those are healing up, but I had to take time off for it to heal. But in the grand scheme of things, it's not terrible.
What let's jump back to your career for just a second. If you were looking back on your journey from I've decided to change and move away from music into the medical field, if someone came to you and said, I want to be an orthopedic surgeon or I want to be a surgeon and this is what I'm looking to do, what would you advise them to do? Are there areas that you look back and go, I could have done that more efficiently, or that class probably wasn't needed, or reprioritize things? What kind of advice would you give someone that came to you and asked questions like that?
Yeah, and I get that question all the time. The first thing I'd tell somebody if they want to go into medicine is I say, can you imagine doing anything else with your life? And if the answer is yes, I tell them to go do that thing instead
Uh,
because the road is so long. Like we talked about
yeah.
4 years of med school, 5 years of residency, maybe a year of fellowship. We're talking about working 80 to 100 hours a week. You're talking about potentially $300,000 of debt for medical school.
Mm,
I'm 35 years old and I just recently started my practice as an adult independent surgeon. So it's
Yeah.
a long, long road. So with that caveat out of the way, I would tell people that probably the most worthwhile thing they can do is spend as much time in hospitals and with doctors as possible so they can really get an idea of what the culture is, what the life is like, if it's something they really want to do. I'm sad to say I've seen people get through medical school and then they get into residency and they hate their life and they said, this isn't what I thought it was going to be. And they ended up quitting, which is a
Ooh.
shame for someone to spend that much time and money and dedication to get some excellent training and then not finish and do the job.
Yeah.
And that's not to blame those people. I think a lot of ways the system is not kind to us. It chews us up and spits us out in a lot of ways. But I think the best thing you can do is expose yourself to medicine as much as possible so you can understand what it is that you want, what your goals are in life. And maybe this is a more of a philosophical discussion. And maybe you're looking for something that's a little bit more of tangible advice. And
No, it's
um,
philosophical or practical. It's both plays in.
so I'll stick with that being the most important thing. As far as the more of like what are the physical actionable things you can do,
Hmm.
um, it's all pretty well laid out. You talk to your class counselors on what it means to be pre med and what's required. Um, as long as you take those classes and you stick to it, you get good grades. It's pretty much laid out for you on that setting. I will tell you who you know is important. So if you can make friends with these doctors that you're shadowing and working with and get good letters of recommendation, or they
Hmm.
can make a phone call and say, hey, this person's a very strong candidate, you should consider them. That goes a really long way because there's so many applicants who have just fantastic test scores. So being differentiated is hard these days. So it is important to have people who will make phone calls for you. As corrupt as that might sound, it's very important. It's all about who you know.
Well, yeah, networking and having contacts certainly can help. When when you have folks that are looking into the medical field, do you find that most of your counterparts are extroverts? Are they introverts? Do they have a lot of common personality traits? The people that kind of rise to the top, are they usually cut from the same cloth, or do you see all kinds ending up in your line of work?
Again, it falls sort of on specialty. I think different
Ah.
specialties attract different people. Surgeons definitely tend to be more of that, what you'd say, type A personality, very assertive, like controlling. They want everything
Hmm.
just so. They're very particular. That surgery just draws that type of person. As you can imagine, pediatricians tend to be a little bit more bubbly and outgoing and love children and love they're playful people in general.
Yeah. Hmm.
Then you meet radiologists and pathologists. They tend to be more introverted. They spend their time alone in rooms without windows. So, all of these are stereotypes, but they're stereotypes for a reason because
Hmm.
these specialties do attract different people. So, and medical school, that they do the best they can to expose you to every subspecialty and field of medicine so you can get a feel for what it is you want to do. There's exceptions. A lot of surgeons have this stereotype of being kind of unfriendly jerks. I like to think that I don't fall into that stereotype, but I guess you'd have to ask my staff.
Well, what do you think that medical school, you've been through it, I'll say recently, even though I know it's been a number of years, but what do you think that medical school gets right and what do you think they get wrong? And I know that that's an extremely broad question, so just hit the high points if you can.
Sure. Yeah, I'll do my best. That is very broad, but
Yeah.
I'll tell you the first thing that come to mind. Uh, One of the most formative parts of medical school to me was the cadaver lab.
Okay.
You are cutting into a real person who is deceased. My school had a full cadaver lab, but there's actually a trend nationwide that they're trying to move to virtual cadaver labs where you're not actually touching a real human. You're doing it all sort of on 3D projections and going to the body that way.
Hmm.
I think that's a huge mistake, and I don't like to see that trend. I think the reality and gravity of working on a real human body for the first time it's very disturbing actually the first time you see a dead body in front of you. But
Hmm.
my school did a very good job of saying this is a human, you need to treat this human with dignity, this person donated their body to science. So I think my school did a great job, and I don't like to see people going away from that. I think it's very necessary. So that's one of the things that comes to mind. They preach a lot about the philosophy of medicine in school, about empathy and caring for your patient. But what I don't see a lot of is talk about how do you manage your life after med school, after residency. This whole notion of You work hard, play hard plays out really profoundly in medicine. We work so hard, and we drive ourselves into the ground, and then a lot of times we get out and we don't make the best decisions sometimes in our social lives. And I've seen that play out with a lot of my colleagues, unfortunately. Make poor decisions, maybe binge drinking, maybe drugs, and it ends up really damaging them professionally. I'd like to see more of a focus on how do you manage your social life, how do you manage relationships, how do you manage money. You go from making $40,000, $50,000 as a resident to suddenly making anywhere between $200,000 and $600,000 as soon as you finish. And people have this massive amount of windfall of money, and they do not manage their money appropriately, and that can be a big problem too. I think the whole education of medicine is done fairly well, but I think managing your life and managing what it means to be a doctor sometimes falls through the cracks.
Boy, that was an excellent answer. What is it that you like about your job the most, and what is it that you dislike your job? What about your job the most?
That's easy. I love when someone comes into my office and they hurt and they have a disability. They're not able to walk. They're not able to use their arm. And when I'm done with them, they're able to do that again. They're either pain free or have much less pain. They're able to use their arm again. They're able to do what they love, whether that be play golf or pick up their grandchild or just be able to take their walk every day again. That's just there's nothing touches that feeling. It's incredible.
Yeah.
What I hate
What
the
do you
most is insurance companies. you know,
That's not a
this
surprising answer at all. That
it's predictable and it's everywhere.
Yeah.
You see doctors on Instagram and TikTok talking about it, and
Yeah.
it's there for a reason because I try to take care of my patients the best I can. So this patient needs surgery, and then the insurance company says they have to try 6 weeks of physical therapy before we'll approve surgery. I said this person is in agony if they have a torn rotator cuff tear. You know what? You don't want me to fix it? That's it's just horrible.
Yeah. Doesn't sound like there's much common sense applied to the scenario, but what mentors, if any, did you have early on in your career or when you got to your residency or moving forward in your medical journey? Did you have anybody that kind of took you under their wing and kind of said, "Hey, this is how you want to do this," and kind of guided you and gave you some solid advice?
Yes, more so in residency and beyond than in medical school. In
Okay.
medical school, I kind of felt like I was on my own. I obviously met some good doctors when I was there and had good teachers, but I felt like I was just lost in a sea of medical students and sort of just fended for myself.
Hmm.
And that's not me trying to criticize anybody. It's a massive system, and you have to get through it. And everyone finds different ways of coping. My coping was exercising a lot, and I had a small group of friends. We all studied together. Um, Medical school was less fun to me than residency, even though I worked even more in residency. But in residency, I had lots of good role models and people that I really looked up to who would take me aside and mentor me in the way you'd want, both in the education standpoint and the sort of spiritual philosophical standpoint. I know it's not a political or religious podcast, but I am a Christian and I have Christian values, and that really is very formative in the way I make decisions in my life and how I take care of my patients. So it was very important to me that I had some other people who at least shared my religious beliefs, who could show me how they live their life in the context of being a surgeon and how to take care of people, and that was very important to me.
Do you have classes in medical school that, uh, when you sit down with a patient and have to deliver some bad news to them, some people, it's not their personality. They're not prepared for that. I know when I got in the fire service, the first couple times I had to deal with someone whose loved one was right there dying in front of them. You're not, I'm 28, 29 years old. I'm not prepared to have that conversation with someone that I don't know. And experience taught me a lot in that, but there weren't any classes or just like a chunk of skills about how to navigate that minefield. Do they do that in medical school at all?
They do. There was at least in my school, it was called the practice of clinical medicine. There was a curriculum where it was how do you treat patients professionally? How do you interact with them? How do you communicate with them? And that was definitely one of the topics. And we actually had patient actors that we worked with, people who pretended to be sick or have illnesses or
Oh,
have problems. And we, I don't know if you ever watched the old Seinfeld episodes where Kramer got paid to be a patient actor.
Oh yeah.
And he had to pretend he had hepatitis or something like that, or
Yeah.
syphilis, and
Hmm.
it's kind of like that. Obviously, not quite as goofy, but
Right.
they and so they would have the Breaking Bad News day, and they did train you. But as you can imagine, as someone who has you've lived that experience of having to break bad news to people, nothing really prepares you for it. Um,
Yeah.
but as you learn to better empathize and communicate with people, it gets easier. But
Sure.
I've definitely had to deliver devastating news to people, and only recently I've diagnosed a few different people with cancer,
Hmm.
and it gets easier, although it's always painful. It always takes a little piece of your heart when you
Yeah.
do it.
When you look at an up and coming student that is in medical school, and now you're on the observing side for these people that you can relate to what they're going through, the nerves and the uncertainty and trying to remember everything and whatnot. What kind of soft skills, when you look at an up and comer, do you see that the guys or the gals that are at the top, the ones that do well, what type of soft skills do they typically possess that allow them to kind of separate themselves from the competition?
Th- This is maybe a little bit controversial, but I really think there's really only one thing you need to be a good doctor or medical student is just to have a great attitude and want to learn and work hard. Maybe a little cliche, but I've worked with students that they never say no. It's always yes, sir, yes, ma'am. I'll get it done, and they just are eager to learn and help. But
Okay.
then I've also met medical students who are like, nah, I don't want to do that. I don't want to do the thing you just told me. I don't see how why that's useful, and they're very entitled.
Mm,
And they can be the smartest person in the world and have the best test scores. That person's not going to be a good doctor.
right.
It's your profession is to serve other people even when it hurts and is uncomfortable. And if you're going to cut corners because you don't see how it serves you, it's gonna you're gonna probably gonna hurt somebody someday.
Well, they're putting themselves first over the patient with that mentality. Would you agree?
I absolutely would agree. I know some people who got into medicine for the prestige and the social status, sometimes for the money. Although I
Mm,
always say doing medicine for the money is stupid because of all the debt you go into and how long it takes to become a doctor.
yeah. Well, I think there's this image that, you work 3 days a week and then you spend your days out golfing and partying and you have a ton of money and life is easy. And that's not accurate. And then you also overlook what is it, a decade of schooling and then the debt and whatnot. There's a lot that it takes to get to that point. So you can't overlook that. But
If you include undergraduate along with all the rest of my training, it was really about 15 years of
good
school.
grief, man, I could barely make
And
it
and I
through
will say
community
I
college.
yeah, exactly. I will say I get paid. I'm compensated very well for my work. There's
Mm,
no one's going to be crying over the orthopedic surgeon saying they don't get paid enough money.
yeah.
But it's not an easy life. I work. I'll still work 60 to 70 hours on a week. It's not unusual for me. So we work very hard.
You're on call too, typically. Do you rotate the on-call type stuff, or is that the on-call mostly for the folks that are newer, or how does that play out?
Every hospital, every practice is different.
Oh, okay.
My The way mine works is I work with a private practice with 12 other orthopedic surgeons. The local hospital here pays us to take call to cover any trauma that comes into the emergency room that may need attention from an orthopedic surgeon. Typically, anybody over the age of 50 gets out of the pool of people in call. So as you become older, say, okay, this person doesn't have to take call anymore. So currently, I need to do my math here. I think there's 7 of us in the call pool. So just divide that up, basically the responsibility, but by 7 people. So it
Mm.
comes out to not a terrible call schedule. Um, I don't have any children, so I often will take other people's call, especially around, say, spring break or holidays. So I do that for my partners who do have children.
Well, that's good arrangement. What is your best advice for someone that is dealing with failure? I've said it on every podcast that I've done. We're all human. Even the best of us, the most trained, we're going to make mistakes at some point in our career. What is your advice on how to deal with that when it happens?
I wish I knew. No, I have a few different ways of coping. I think, and this takes time and it takes experience because, like you said, everyone makes mistakes and everyone has outcomes in surgery that they didn't want and they didn't
Mhm.
expect, and you have to learn how to deal with that? There's a couple different ways I handle it. One is to talk to other professionals and say, this happened. Please give me your advice, run them through it. I said, and they're also going to give you, they're going to give you practical advice on how to take care of a problem. And they're also going to give you emotional, philosophical advice on how to process that.
Okay.
My other, this is a good story. Again, it's going to be a little bit more on the spiritual side, and I apologize for that.
That's okay.
When I first started independent, meaning I was the surgeon, everything fell on me. I had so much anxiety. I'd wake up at night thinking about, I hope all my patients are okay. What if this person's not doing well? And my response was to just say, look, this is not in your control. There's a higher power, and this is out of your control. And you can pray for your patients, but you can do the very best that you can do as a surgeon. But eventually, there are factors that you cannot control, and you
Mm-hmm.
have to learn to accept that and have faith that there's a higher power than you. You can be any religion, you can have any spiritual outlook, and I think that's probably something that's healthy to adopt in any profession. As long as you know that you are putting the utmost excellence and perfection into your work, that the rest of the whatever happens after that is out of your power.
Hmm. I want to go down a rabbit hole for just a second. And one of the nice things about having a podcast is if there's a topic that is of interest to you, then you can ask about it. And since I'm in the fire service and I deal with so many coworkers that have had serious shoulder injuries, the rotator cuff tear is extremely common specific to the fire service. And it's always these random little reaching over your head to pull the hydrant hose or the 5-inch hose as we call it, or using hand tools, swinging, things of that nature. Sometimes it's just a random little, I'm old or I've overused my shoulder so much it's a repetitive type of thing and it finally just gives out. Are there any, let's hit the hot spots as far as any types of exercises or stretches or anything that people can do to really help strengthen and protect their rotator cuff from that type of common injury?
Great question. And I'm going to give myself a little plug here. And I actually covered a little bit of this topic on injury prevention on my podcast on the Wellness Blueprint.
Yeah.
There's a lot of different factors that come into play here. And I'm going to give you some general advice, although this can apply to any joint, whether it be the shoulder, the knee, the ankle. The most generic advice I can give you if you want to talk about exercises to rehab a joint is slow negatives. When I say negatives, I mean if you're doing a lateral raise with a dumbbell, as you bring it up, what you want to do is hold it at the top position and just incredibly slowly with controlled rate lower the weight. And that's going to be the best generic type of exercise to help strengthen what would I'd say a tendon with a that may be prone to injury.
Okay.
Rather than focus on moving weight fast or big heavy weight, you want to have a slow, controlled negative portion of the lift. That applies to just about every muscle and tendon in the body. The other factor that's so crucial that a lot of us can't control, and I imagine firefighters can't either, is getting good sleep.
Oh,
When we
gosh.
don't have yeah,
Yeah.
I bet you
Yeah.
guys have a really hard
Oh,
time with that.
yeah.
When we don't sleep, our cortisol levels aren't balancing correctly. Our circadian rhythms aren't able to function the way we want them to, and we're more prone to injury. One is just the hormonal component. The other is we're less coordinated. We're more prone to injury just because we're not as coordinated as we should be, and we make bad decisions, and we're not as body aware as we should be either. So there's multiple factors at that. Down the line, it's also poor nutrition. You're eating more sugar and inflammatory foods rather than having enough protein in your diet. So it's multifactorial, but I think sleep is probably one of the big things that affects a lot of us.
Two questions. First one is when you initially started answering that question, you talked about the negatives and the slow negatives. When you put that into practice, would that be a light weight for a number of repetitions or a heavier weight for fewer repetitions? Or does it matter?
I would tend to do a lightweight for more repetitions.
Okay.
If you start doing, let's say you're doing that lateral raise and you count to 4 as you lower that weight, that gets heavy pretty quick.
Okay.
It's hard to do with a heavy weight. You're naturally limited to a lighter weight to be able to still keep good form and slow pace.
Okay. The other question was, are there any I know everybody wants to take a pill or a supplement to basically avoid doing, eating clean and all that kind of stuff, but are there any supplements like magnesium or something that we just don't get enough of in our diet that are very beneficial for tendon strength or ligaments or joints in general?
Controversial.
Uh-huh.
You'll find some data saying yes, you'll find some data saying no, there's no difference. Most Americans do not have a great balanced diet and do not get a lot of good micronutrients. So my top supplements that I take would be vitamin D,
Yeah.
and zinc and magnesium.
Okay.
So magnesium and zinc are both play a huge role in healing and musculoskeletal recovery. And vitamin D, like that just has a whole host of different factors, including muscle recovery, bone recovery, immune system, even insulin sensitivity, like combating diabetes. So these are all relatively cheap and available supplements that you are easy to get over the counter. Now, there's a whole host of other things that you can take as well, but those are my top three.
I A little bit of a rabbit hole. I recently read that if you're taking vitamin D, you want to take it with K2. Have you heard anything about that?
Yeah, that's a big topic right now. You certainly don't have to.
Okay.
You do want to take D3. That's the most bioavailable form.
Okay.
And most people, you may want to talk to your doctor and get your blood levels checked just to see. But most people, just playing the odds, need more vitamin D. You'll
Okay.
occasionally find someone who has enough, but that's pretty uncommon.
Does vitamin
As
D,
far as the oh, sorry, go ahead.
I was just going to ask, is vitamin D, do you need to take that with fat?
It's a fat soluble vitamin, but what that means is it just is stored in your fat stores. You don't need to take it with fat, although I've
Okay.
read some studies to suggest that it might be taken better with food rather than on an empty stomach in terms of absorption.
Okay.
As far as the K2 goes, I think the two are synergistic. So if you had to choose between one supplement or the other, I would take it with the K.
Okay. To go back to the rotator cuff stuff, was there any other pieces of advice that you had for folks that are looking to strengthen up their joints? I've heard isometrics are kind of the hot thing for joint strengthening and tendon strengthening.
Yeah, isometrics are where you basically just hold a contraction in a single
Yeah.
position.
Okay.
So that metrics talking about the length of the muscle, so the muscle's not changing in length. Uh, the There's this idea of tensioning a ligament to make it stronger, and this is certainly true. I'm not convinced that isometric is better than what we call eccentric, which is the slow negative.
Okay.
I think both of them are good. I don't know that one is really better than the other.
Okay. I think I know the answer to this question, but I always ask folks if there was another occupation when they were younger that they thought they wanted to do, and yours was music. But do you do anything on the side that, I mean, you have your podcast and stuff. Do you have a pretty full plate and you're kind of set where you're at, and this is your gig, or are there other things you're looking at, like writing a book or something along those lines?
I'm currently writing a book.
Oh,
It's it's about residency. I don't expect that book to be done. I have very little time to work, as we
mhm.
talked about. I don't expect it to be done for another few years, just because I just write so little at a time. Basically, if I go on vacation, which when my wife forces me to go on vacation, that's when I work on writing.
Okay.
but but I do plan on publishing it if I can. My father is also an author, so he has some insights into that world. So he publishes. Um, and as far as what I enjoy doing, it's mostly exercise related, jujitsu, powerlifting. Although I don't compete in powerlifting anymore. My one passion of what I enjoy doing is travel. My wife and I have been all over the world. We love to be in the outdoors and hike and see all these amazing places around the planet. So I don't know that you could turn that into a profession, but at one point I was a professional musician. And I think I'm very blessed to have been able to do two radically different things with my life and end up where I am now. I don't know if I
Very
really
cool.
answered that question much as rambled.
Well, no, that's fine. It's just kind of neat. It's always interesting what people, when they see their life, there's nothing wrong with being in your career. I think sometimes we're led to believe that you always need to be looking for a change. If you're happy doing what you're doing and you're good at it and you get satisfaction out of it, there's nothing wrong with staying with it. So that's kind of why I ask.
Well, on that note, the reason I started my podcast is because as an orthopedic surgeon, I usually I'm fixing a problem that's there.
Yeah.
You hurt yourself, you broke something, or you have horrible arthritis, or you tore a muscle. And I thought, well, I'd love to find a way to get back to my roots. You remember I talked about the reason I got into medicine is because I enjoyed fitness and nutrition and health. So that orthopedics doesn't really cover that so much. We're really fixing a problem. So that's why I
Mhm.
started the podcast. Is like, here's information I wish people had to stay healthy and not need orthopedic surgery. And so that's sort of feeding that passion right now.
Okay. Tell us about your podcast.
Well, it's me and my wife. We do
Yeah.
it together. We have a lot of fun, which makes it really easy to record because I get along so well with my co-host.
There you
But
go.
I pick topics. Our first two episodes were about inflammation. What does that mean? What does that mean to you? How can you change it? I did two episodes on sleep on importance like that. But we just pick topics. I did a deep dive on what is vitamin D, like how does it work? What's the chemical structure? Why is it important? The next episode was just going to talk about just what is protein. Why is that important? So we'll do some very general topics, or we'll talk about. We did one on seasonal affective disorder and why mental health is so important to your physical health. It's a very wide and broad range of things, but hopefully my goal is to give people actionable topics on how they can improve their life.
I hadn't seen the one about sleep, and I've got all kinds of sleep issues, and so do a lot of the people that I work with. I think being a first responder is just kind of part of the territory. But I did see you did an episode on caffeine that I also plan to go and listen to, because we always have the coffee pot going in the firehouse, which I'm sure you do at the hospital as well.
Oh yeah, I lived on energy drinks when I was a resident.
Oh man. Well, thanks a lot for your time, Dr. Caleb. I really enjoyed talking with you. You provided a lot of good information. And if anybody wants to find your podcast, it is called the Wellness Blueprint Podcast. And again, it is on Spotify, Apple, Amazon, and YouTube. Is that correct?
That's correct.
All right.
You can also check out drcalebdavis.com for more info. And you can follow us on social media at Wellness Blueprint Podcast.
Awesome. Thank you for your time today. I really appreciate it.
I had a great time. Thank you so much.
And that wraps up another episode of the Jobs Podcast. Thank you so much for joining me today. Hopefully you found that interesting. As always, I wait until the end of an interview to ask you to like, subscribe, and share. I feel it's important that I earn that support from you. Thanks again, and we will see you on the next one.